My name is Julie Steenheisen, and I'm a health and science correspondent for Reuters. This is a live online Q&A about COVID-19 testing, vaccines, and how they can work together to be scaled up to help curb the next phase of the pandemic. With me is Dr. Michael Mina, Assistant Professor of Epidemiology at the Harvard T.H. Chan School of Public Health and a core member of the school's Center for Communicable Disease Dynamics. You can post your questions for Michael and me on Facebook at Forum HSPH, or you can email them to the forum at hsph.harvard.edu. This Q&A is jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and Reuters. I need to start out by correcting the pronunciation of your last name, Michael. It's Mina, like Minnesota, right?
That's absolutely correct. Yeah.
All right. Well, sorry about that.
No problem.
So Michael, for months you have been advocating for widespread rapid home COVID testing. Where are we with that kind of testing, and how might COVID-19 testing more generally be impacted by these new variants that we're hearing about, mutants of the coronavirus?
Yeah. Well, we are. I wish I could say that that wide-scale at-home rapid testing was available to everyone who wants it right now, but it's still not. I was certainly hoping that this would become a program that would have become available and really pushed by the federal government back in July or August, and still been beating the same drum, trying to get this as a tool. But we are starting to see, I have a number of them right here. We're starting to see a pretty big variety of different tests. A lot of them look the same. For example, these are three unique tests from different companies. These are really rapid antigen tests, similar to the Binax Now test that the US government purchased quite a while ago. That there's been some controversy over it because they haven't been well utilized by many of the states, despite being given by the government. And that's unfortunately been because there hasn't been a lot of direction, particularly in the previous administration, about how to potentially use these tests. But now one of the things that's very exciting to me is we're starting to see sort of version 2.0 of these tests come about. One of the major reasons these antigen tests here haven't really been widely deployed across the whole population is there's still confusion about, are they sensitive enough? Are they specific enough? The short answer to both of those is, when it's for public health, yes, they are absolutely sensitive enough and they are absolutely specific enough. But now we're starting to see really cool new devices come about. This is actually a PCR test, essentially, that you could use at home. And it doesn't require a big instrument or anything. And so we're starting to see all of these new tools come about that maybe the FDA and other regulators will feel more comfortable with, because they'll better mirror the laboratory-based PCR tests, and they'll be very expensive and at home. So I'm still trying to work to get these tests available to everyone, and I think that over the coming month or so, we should probably see some pretty big changes and some big decisions that will probably get many, many more of these tests out into the public. The second question that was asked was, what's happening with these strains, and are they affecting testing? That's been a major source of concern. The short answer is almost all of these rapid antigen tests, and most of the other tests as well, very few, if any, are significantly impacted by the variants. The variants, they all are, the mutations are being made on the spike protein of this virus. But the spike protein isn't the most abundant of all of the proteins of the virus, so very few tests are really targeting the spike protein to look for it. And so these are generally not impacted at all by the variants against the spike, because they're looking for what's called the nucleocapsid. There was an interesting occurrence, though, which is probably what's made a lot of people so worried about this, which is that we saw a dropout in one of the tests. There was a Thermo Fisher PCR-based test that was impacted, but it turns out there was a silver lining there. It's a PCR test that looks for 3 different targets. So it turned out that if you find 2 targets with 1 missing, it was still a positive, but it was actually giving public health officials an understanding without even having to sequence that, hey, this is the B117 variant, the more transmissible variant that arose in the UK initially. And so the short answer is they're not impacted greatly by the variants, but the one that has been impacted, it's actually been a benefit for public health to be able to monitor.
Is anybody working on a test that would be like an at-home test or a rapid test that would be able to detect the South African variant? Because my understanding is that that's one that's even more concerning.
Yeah, well, that's a great question. So far, most of this is being tackled through sequencing. So you get a positive sample and it gets sent for actual sequencing. That being said, I know that there are discussions with some of these molecular testing companies that are making the at-home molecular PCR-like tests. This is a LAMP test. And this is the kind of technology that could do exactly what you're saying. You just have to change the primers. And if you change the primers and where they bind on the and to what genetic sequence of the virus, to the mutated sequence, then this very simple at-home test could turn into a test that's very specific for a mutant version. So for example, I could envision you take a detect test and you have sort of like your base model, and it will catch any of the any of the variants or the original strain. And then if you get a positive, maybe then you pull out the second test and you look for mutants with sort of a similar but slightly different version. So it could really, I could envision a world where we can do that very readily.
I want to jump to another topic. So in the United States, we're very close to a pretty grim milestone, 500,000 deaths from this coronavirus. I'm wondering, what is the significance of that to you, and how did we get there?
Wow, talk about a loaded question. I mean, the significance is extraordinary. I think I've been extraordinarily frustrated. There have been days when it's been so readily apparent that that society has largely become numb to the exceedingly high number of deaths. When we passed 1,000 deaths per day in the United States, that was huge. But then when we passed 4,000 deaths per day, it was barely anything. And so we've got into a situation now where I think the numbers have gotten so large that we lose track of just how devastating this is. To me, it essentially shows that we have not done this well. We have failed essentially to tackle this virus, and we've failed since the beginning. I think we are starting to see things turn around, but what this number to me, from an action-oriented perspective, suggests is we need to think of new approaches. We need to take new approaches. We've seen policymakers and epidemiologists continue to drive the same approaches over and over for a year now, and they haven't worked. We've gotten to 500,000 people, and so part of what I've tried to do is look at the facts on the table and say what we are doing is not working. We can say the words all we want: test, trace, and isolate using laboratory-based PCR, distance, mask. At the end of the day, it didn't work, and some of it did help. But I think we need to pivot into whole new directions, and that's where vaccines obviously are a major benefit here. But also some of these rapid test approaches, we still haven't tried it. And I still believe that these alone can stop outbreaks from continuing. And so I think that this 500,000 number really represents to me a failure to think creatively in the midst of an emergency, to not respond appropriately in the way that we really need to respond. And I hope that we can learn from it for the next time, because this will not be the last pandemic like this. Travel is only getting more robust and more frequent. We will see global pandemics in the near future. I hope none like this, but it's very likely we will, and I hope we can learn that we need to act incisively. We need to act urgently. We need to try, and if things aren't working, we can't just keep beating our head against the same wall and hoping that headache will go away. We need to try something new.
You know, we mentioned variants earlier, and and you just mentioned the rollout of vaccines, but my understanding is that some of the variants already are undermining the efficacy of the vaccines, particularly the variants that originated in South Africa. And so how do we use testing to preserve the new tools that we already have and maintain the efficacy of those vaccines?
It's a great question. The best thing we could possibly do to improve the effect of the vaccine, to improve the chances that the vaccine will continue working, as we're hoping it will, is to reduce cases as much as possible without having those reductions occur as a result of vaccine-derived immunity. If we have millions of people out in the world with infections and millions of people who have been vaccinated, that's billions of combinations of times when somebody might be, when a virus is coming in touch and in contact with somebody's vaccine-derived immunity. And every time those touch an antibody from somebody who's been vaccinated and a virus, because somebody inhales a virus who's already immune, every time that happens, you hope that the antibody defeats the virus, but there's always a potential that the virus will mutate randomly. That will just be, it will have its one chance essentially to find a new way to kind of go stealth on that antibody and not be detected. And so the more opportunities we give the virus to come in contact with somebody who is immune, the more opportunities there are for the virus to find a way around that level of immunity and those antibodies. And so where tests come in here, and all of the other measures, masks, distancing, and tests, those can help preserve the vaccine by reducing the numbers of cases that are coming in contact with people who have been vaccinated. We want to slow spread down as much as possible. It sounds a little bit counterintuitive because you'd say, well, we're giving the vaccine exactly to do this. But instead, what we should really be saying is we're giving the vaccine for the long haul. Right now, we need to drop cases as much and as quickly as possible to reduce spread and reduce the chances that mutations will continue to come about. Because, one thing that we really, I think, did not put pay enough hard attention to is that this was a baby virus that just jumped into humans. We thought that we could have years before this thing mutated away from our immune system, but we failed, in my opinion, I would say, kind of as a global scientific body making vaccines, we failed to account for the fact that this virus was just learning to stretch its legs. It was just learning it had so much room to grow and shift and try new things. It wasn't optimized when it jumped into humans for the first time. And now it's finding, hey, okay, humans are throwing this, that, and the other thing at me, but I still have lots of room to shift and change. And we don't want to give it those opportunities.
We have seen a tremendous investment in vaccine development, and now that investment is paying off. Why haven't we seen a similar investment in rapid testing?
I would say because we were generally short-sighted, to be frank. The biggest reason, though, it's not really fair for me to say that in that way. I would say that this approach that I've been pushing for rapid testing is it's a new paradigm for what a test can be. Vaccines make sense. There was no way we weren't going to build a vaccine for this. And thankfully, we were successful in building effective vaccines. But that was a no-brainer. What do you do? Textbook 101 for novel virus comes around, try to build a vaccine. In this case, the idea to create a new science around testing, and that's essentially what we did, has really been an uphill battle. And the reason is a fewfold. On the one hand, most epidemiologists are not in the testing space. They don't understand the metrics of testing. I'm in a unique position because I do wear an epidemiologist hat, but I also am a laboratory director in a hospital where I oversee testing. So I got to bring these together in a way that made sense. But most epidemiologists have kind of stayed out of the testing discussion because it's just not their domain. They're used to studying vaccines and immunity and herd effects and such. And then on the other hand, all of the people who normally are asked questions to by people in positions of decision-making power are usually laboratory directors when it comes to testing. But the type of testing approach that I'm referring to here with these little rapid antigen tests, these are distinct from the type of tests we would want a laboratory director in a hospital to necessarily be using. And so it's been a very difficult approach to try to get a whole new science surrounding testing into the mainstream when all of the people who would normally be asked about testing aren't really the right people to ask about these tests. And so it's led to a massive confusion across the globe, and including at our own CDC and our own FDA, who generally haven't really understood sort of the biology of this virus and what it really means for these particular tests and how to evaluate them appropriately. And so everything has been sort of an uphill battle to change the discussion, to try to get people to understand that that we need to detect people when they are most infectious, meaning when virus is very high. Detecting people post-infection might be good for medicine, but it's not good for public health. These are oddly kind of new concepts for this kind of virus.
I'm wondering if the landscape for rapid testing is going to change under the Biden administration.
Well, I think so. Biden has made it very clear, even before he got into office and since, that they want to support and build rapid testing as an approach to help open schools, open the economy. In his sort of, in the Biden-Harris administration sort of overall plan, they put $50 billion towards testing in general. Is a fairly vague bucket. And so what we've been working on is to try to essentially get 20 of that 50 to be allocated towards public health testing programs that are going to be distinct from the ones that we have been using so far. And that would be these rapid tests. I would say that some of the very first announcements that Andy Slavitt, the president's senior COVID advisor, has made have been around rapid testing. I've been somewhat critical of them to a certain extent. Again, maybe somewhat unfairly because they were brand new. I should have just been happy that they were, really pushing the envelope here. And I would say that that was sort of week number one. And so since then, they've really started to build up steam in terms of what their overall approach is for testing. And a lot of it has been centered on supporting rapid antigen tests, including Athome initially. They came out a week later with an announcement that they were going to be investing in 6 companies, I'm not sure what companies those are, to build up fast tests by summer. And now we're trying to even give them even more tools with some of these other companies like Innova and Abbott and Access Bio and some of the others. I think they're now realizing, hey, these tests actually could exist in very large numbers today, and they're able to start making decisions around that information.
Is there a regulatory change that still needs to happen?
Yes, I think so. And I've also been quite critical of the FDA publicly about this. But also, what doesn't always get across when reporters report the words that are coming out of my mouth is I say that, but then in a big caveat. And the caveat that I say is, the problem isn't so much, it's not on the people who are currently in charge of this at the FDA.
Mhm.
What we really need is there's the in vitro diagnostics division, which is headed up well, it's at the FDA, and they're in charge of doing exactly what that title is, in vitro diagnostics. I want this to be a public health test that is not a medical diagnostic, but rather a transmission indicating test. And so I think what's happened at the FDA is a symptom of a larger problem that we have defunded and totally devalued public health to the point where at our own FDA, we don't even have a public health language for what a public health test could. We don't have a language for what a public health test could even be, what metrics need to be used to evaluate it. And what I would say in the FDA's defense is they have been, Tim Stenzel in particular has been very willing to listen and think creatively about how to, within the sort of bucket or within the sort of pathway that he's been handed, which is in vitro diagnostics, to try to figure out, is there an approach within that pathway to get these tests authorized more quickly? My hope in the long term is that this is a short-term solution. My hope in the long term is that FDA will build a whole new pathway that's not in vitro diagnostics, but that is public health devices. And they really require a whole different type of thinking. They need to incorporate not just the biological metrics of the test itself, but really think about what is the manufacturing landscape of the test, what's the turnaround time of the test, can we use epidemiological models to help authorize a public health test? So I'm hoping that the Biden administration maybe, or the new HHS will push for that over the coming years.
I want to take a couple of questions. We've had several questions from people who are listening online. This one comes from Jim. Jim asks, with the new variants, if I would get reinfected, would it be likely that I would have a less severe case since I had a different variant in October?
The short answer is yes, most likely. We believe that, especially for people who have been infected already. The nice thing, if this is a virus, people will develop antibodies to all different parts of the virus when they get infected. And so if just the spike protein changes a bit and gets hidden, for example, you can still have all these little antibodies that recognize the other parts of the virus. And so if somebody were to get infected a second time, even with this mutant, while they might not have as good a response to the one protein, the spike protein, which is really the most important for neutralizing, we believe, we also believe that between T cells, which can detect different parts of the virus, and different antibodies detecting different parts, that people will still retain a very good amount of immunity. And so even if they got reinfected, ideally they won't get severely infected. And if anything, there's even a chance, I've said this many times in the past, reinfections are normal. We actually want reinfections. It sounds crazy, but the immune system needs to learn. And in the same way that if you or I study for a test, we don't just read it once and say, okay, we're good to go. We read it multiple times. We studying is about training, just like exercise. And the immune system is also built on similar principles of memory. And it needs to actually be reminded, which is what a booster is largely about, and what re-exposures are about. But what we really want is for people to first get some vaccine-derived immunity, and then if they get a re-exposure maybe in the future, or a first exposure to the natural virus, for example, then they can boost their immunity rather than getting sick, and hopefully set themselves up for a future self will be in even better shape.
I've got a question from Ron. We've been living with this virus for a year now. Can we say with certainty whether or not this is a seasonal virus? And how does this inform how we should be planning for the summer and for next fall?
Well, I wouldn't ever want to say anything's for certain, for sure. But I do feel that thus far, in my opinion, the virus has played by the rules of coronaviruses. It has My feeling about this is nothing, I mean, really very little about this virus has been surprising. And the reason I say that is because it is following what we know of other coronaviruses in terms of seasonality, or at least the patterns thus far largely reflect that. Now there was confusion because people said, oh, it's not a seasonal virus because look, there's still cases in the summer last summer. But we really shouldn't confuse continued outbreaks, especially when you have an entire population of susceptible people. There's this term we use in epidemiology called the force of infection. You could think of it like the momentum of an outbreak. And if you have a huge amount of momentum, then even seasonal effects might not be able to tamp it down. And that, I think, is what we maybe saw in the summer last year, where we saw a lot of the southern states were getting infections and outbreaks. But then, sort of like clockwork, exactly as we anticipated, or at least, I don't want to speak for others, but at least I anticipated, based on what we do know about other coronaviruses, this virus took off in November, December. And frankly, now it's actually coming back down again, also exactly as other coronaviruses normally do. Now, I think that it coming back down is a reflection potentially of seasonality and potentially of some immune herd effects that are taking place because a lot of people have now been infected. And so what this means, I think, for looking forward is if seasonal effects are real, and if this is abiding by some of those, then I hope that in the United States, we'll be entering right now into a reprieve of getting down to lower numbers of cases. It won't go to zero. But this is our chance then, in the same way that last summer was our chance and we didn't use it. I don't want us to make that same mistake again. This is our chance to really try to tackle the virus while its guard is down and get ourselves into the best position possible for October and November of 2021 to stop outbreaks from raging back. And we don't know what's going to happen with the variants. And so that it just makes getting these types of tests that can be adaptable. You don't have to use them every day when cases are low, but if we get the community socialized to how to use these tests, then if an outbreak comes back in, say, October, November in a community, a simple text message maybe could be sent out that says, we've seen a few new cases in your community, start using your rapid test for the next 2 weeks and let's get this thing to die off again. So I think we still need to keep our guard up and we still need to plan for the future, but let's hope that the next 8 months or so are a lot better for us than the past 8 months.
Here's a question from Sonia. We've been hearing that the vaccines are very effective at reducing illness from the virus, but do we have an answer yet on whether they also prevent people from spreading it? And would you expect different vaccines to act differently with respect to transmission?
So we're finally starting to see some evidence for this. The data, unfortunately, the initial clinical trials did not attempt to measure this, which is a whole different problem of sort of the way that we thought about all the trials and how we've treated this pandemic like it's a medical problem and not a public health problem. But that we'll save that for another discussion. But the evidence today is showing that the vaccines are leading to slight reductions. It's difficult because we're using all population level data, but they do seem to be reducing viral loads. How much they end up reducing the viral load, they're definitely reducing symptomatic disease. They're definitely reducing severe disease a lot. But we're also seeing that people with the vaccine can still replicate virus. And this is not surprising. It's really difficult to create true, what we call sterilizing immunity. That's a type of immunity that we want to create. And that's what these vaccines were attempting to create, where you just kind of stop all of the replication whatsoever. That's pretty difficult to do. And as antibodies wane in people, which is always going to happen, when you get a vaccine, you get a big spike in antibodies and then a lot of it has to die off, and then you ideally keep a protective level. But as we see the protective level, depending on where people's protective level is, they might be more or less likely to have some virus replicate. And so I think it's premature right now to say, you've been vaccinated, don't worry about wearing a mask. That would be a wrong decision and a poor one, especially if you're around vulnerable people. Will transmission be lower? Probably. Will it be zero? Probably not. And so we're gonna hone in that that range over the coming months.
Now I've got a question from Fritz, who is a freelance writer. How will the decision be made to update the vaccines and or to give a booster? And is that made by the companies or by the request of the FDA or HHS or the CDC?
Well, this is a tough question, and I'll be honest, this is the actual decision making is a little bit outside of my area of expertise. But what I can say is the design of the vaccines usually is left up to companies. We did see a very strong collaboration with the Moderna vaccine and the NIH Vaccine Research Center to develop the vaccine. And I would say that companies have certainly been probably more willing during this pandemic to communicate with the government and vice versa, and sort of public health policy folks. It's only in their best interest to continue making vaccines that are going to benefit the public health as much as possible, at least for a time. Of course, there's some conspiracy theorists out there who might say otherwise, but how much real direction do they take from things like the NIH, the WHO? That is, I think we'll start to see a better relationship form, similar to what we see with the flu vaccines each year, where those are really, the companies essentially look to the World Health Organization and look to the CDC to say, you guys are doing all the heavy lifting public health wise, you tell us as a company what strains we should put into the vaccine, and we'll work with you for that. I think that we'll see a similar relationship form here surrounding COVID and the new variants.
School reopenings have been a very contentious issue, and that has certainly been accelerating of late. Could rapid testing help schools open for in-person learning, or how could they? And are you seeing districts adopt rapid testing programs?
Districts want to adopt rapid testing programs. The problem is the tests just aren't available in enough numbers, largely because the ones that can really scale to very high numbers haven't really been authorized. In places, in some states, there's a lot of these Binax Now tests, but there's not, there's a lot that are sitting on shelves, unfortunately not being used right now, that the government bought during the previous administration. They're about to expire, actually, which is a shame because it's something like tens of millions of these tests. But to really be able to use these effectively at the wide scale sort of use to keep schools open, that large number of tests actually isn't sufficient. So right now for this, we haven't really seen enough tests around and available and accessible to policymakers so that they can actually make a plan around rapid tests, which is why I've been advocating so heavily for the rapid authorization of more and more of these tests for public health, or for the FDA to release them from the grip of the FDA and to maybe pass it off to the CDC or the NIH to evaluate as a public health test, especially for things like keeping schools open. One of the best ways that we could help to keep schools protected, along with everything else we're already doing, is to ask students, for example, and their parents to test at home. This test, once you learn how to use it, it takes about 30 seconds. If kids could use this test twice a week, every week when cases are high in their community, and just do that at home and maybe have some pass, take a picture with a cell phone, whatever it might be, that would be a very useful and strategic way to use these tests once they get scaled up to keep schools much more safe. It won't necessarily stop every single infection from entering into a school, but what it will do is it will stop outbreaks from spreading within a school. It will keep the R value below 1 within that school system and stop those outbreaks from spreading. So we could really utilize these to make everyone much, much safer. I know personally that many school systems, many businesses, many states, governors want to use these tests, but they can't really use them until the ones that can scale to very high numbers become authorized.
Okay, here's a question from Pauletta. If I have already had COVID-19, do I still need to get vaccinated? And should I wait and let others go ahead of me in line?
Well, this is, I wish so much that we had set up this program. We knew that this was going to happen. We knew that there were going to be many, many, many people. My estimate is that we probably have around 100 million people in this country who have been infected, which is a huge number of people. Had we set up a system before the vaccines were actually available to check people's serological status, to ask, do you have antibodies already to this virus? And if so, we could have thought more strategically. Maybe we either put them down the line, maybe we only give them one vaccine instead of two. And the literature has shown very well that people who've already been infected who get one dose, that dose acts like a booster. They don't need their second dose. Many of them probably in reality don't need their first dose. And so to answer this individual's specific question, the short answer is, while I would like to say, yes, refrain, I'm not going to say that. I think it's very important for us to keep a very clear public health message and a unified one. And I do think that everyone should just get their vaccine when they're told to get their vaccine. When their place is up in line, they should go for it. Had we had really robust systems in place to allow us to think differently about this process, I would have a very different answer, but we unfortunately didn't get that set up in time. And so now I think everyone who can get a vaccine should really just go for it and get your vaccine.
I was looking at some of the Novavax data from South Africa, actually within the placebo arm, that some of those individuals had already been infected, and when they got infected by the South African variant, they were not protected. So I'm wondering how that advice changes depending on variant.
Yeah, well, so I think that advice, it won't change for me depending on variant, but what will change, something that, this might be a little too complicated for this forum right now, but one concern I have, which I want to give this caveat that it's not based on data. It's based on just my thinking about the immune responses to vaccines and infections. We actually are running some level of risk here. The vaccines we're giving are very narrow vaccines. They're generally just against the spike protein, versus getting infected gives you antibodies and immunity to many other parts of the virus. I have this concern that hasn't been studied yet, but if we are giving a lot of people just this vaccine, and let's say the virus mutates to evade the immunity derived by this particular vaccine, so then the company goes and updates and makes a new vaccine that's very similar, but is a little different to deal with the new mutant strains. My concern is that we might get something called antigenic seniority, where people will get locked in essentially to the first vaccine they got, even if they get a new vaccine that presents slightly different molecules to address the new variants. When they get this new vaccine, they might actually only boost antibodies to the old vaccine and not really develop a good response to the new one. This has been shown, these kinds of things have come up with influenza, for example, where if your first infection was against one particular mutation, you might not respond as well to a new mutation because your body just kind of keeps reverting back to the old one that you first saw. And so I do have this concern, and I hope that scientists will explore it. I'm certainly going to attempt to explore it. But we don't want to find ourselves locking people in inadvertently so that they can no longer respond well to new variant vaccines. I want to be very clear that this has not been shown, but I think it's an interesting piece that I haven't seen enough written about and considered, that I'm hoping that we start to consider this as just part of our broader thinking about, what are the potential, what could go wrong, and is there a way to ameliorate or prevent that now rather than waiting until it's gone wrong?
No, I think this is our last question, but we had a question asking, is it time to consider this virus endemic? And I want to add to that, and what are the implications then for vaccines?
Oh, well, I mean, by definition, we wouldn't call this endemic yet, but certainly I would say by obvious standards, I think we should assume that this virus will become endemic. The important thing, though, is humans will grow out of this virus in a way. This virus will become endemic, but as more and more people get infected or vaccinated and immune, the consequences of the virus as it continues to spread and stay with us into the foreseeable future, and the not foreseeable future, it will become less and less of a burden to our society. People will age out of it. People who are vulnerable will have become somewhat immune. And so even those individuals, barring some really, really problematic mutations, then even vulnerable people who have already been vaccinated or have been infected in the past will likely fare much better than they have been. And so I don't want people to, I do think that this will become endemic, but I don't want people to think that like we are stuck in social distancing and mask mode forever. We will come out of this, and we probably will continue to have the virus with us, which is why I think it's very important for us to start asking the question, what is the end game here? What is our goal? We can't be completely petrified of this virus and close everything down, every time there's an outbreak once people have been vaccinated. We have to come up with something that society is willing to tolerate, very much like we deal with influenza. We have to figure out where that balance is between what society is willing to deal with, what are the economic and social consequences of trying to really focus on the virus itself versus focusing on sort of a broader picture of what is public health in society. And so I think the blow from this virus will become increasingly blunted, even as it becomes endemic.
Well, that's pretty positive. I'll take that. This concludes our discussion. Thank you again, Michael, for fielding everybody's questions. This Q&A has been jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and Reuters. Join the Forum again on February 23rd at noon Eastern for a discussion about the COVID-19 variants and vaccines.